Thank you, sir. Thank you for the introduction. Very good afternoon and a warm welcome to one and all. And it's incredibly an honor to share the stage with Dr. Shanmugavelu, sir. So thank you very much for this opportunity. So this is a very apt session for post-lunch, talking on incretin analogs, right? So incretin mimetics, we are talking about GLP, but we are not talking only on GLP. We are talking about a breakthrough innovation, a single pen that contains your basal insulin glargine, which we have been using for years now, and you also add GLP-1 receptor agonist to the same pen. So it's called as iGlarLixi. That's what we're going to be talking on, a simplifying control. I'll show you some of the evidence and practical usage of this molecule in your practice of iGlarLixi. It's available in the brand name called Soliqua. It's been marketed by Sanofi, and this session is sponsored by Sanofi, and it's been available in the market for the use in type 2 diabetic patients for the past couple of weeks. So this is my disclosure for this talk. So why do we need these regimens? You know, as Dr. Madhav said, we have had multiple sessions about basal insulin. We talked about oral semaglutide and how to place the molecule pre-lunch. And why do we need these complex regimens or the newer innovative regimens in the management of type 2 diabetes? So I am a strong believer of basal bolus insulin. A lot of my patients in the setup, tertiary care setup where I practice, is on a basal +1 or a +2 or a basal bolus concept of insulin. But I do acknowledge with the patients, sometimes I do listen to them about the multiple pricks that they have. Disciplined self-monitoring blood glucose is very mandatory because of the risk of hypoglycemia. I will not disagree the stage that the sugar control is excellent. A lot of my patients do very well with getting their HbA1c to targets, but it is associated with weight gain. That's a complaint that I hear from the patient, and reduced flexibility. So I still continue to use basal bolus, acknowledging that this complex insulin regimen can be associated with that. And what factors can impact this potential treatment? Of course, we need to talk to them about the lifestyle importance of diet and exercise that Nandita was talking about this morning, acknowledge the fact about the multiple daily injections, and also talk to them about the physical activity. So this is the reason why we need newer molecules in the management of diabetes. So what is combination injectable? So we'll move on to the combination injectable. As I told you, 2 titratable drugs. Here in this pen, which I will be showing at the end of my presentation on how to use it clinically, has basal insulin glargine and GLP-1 receptor agonist lixisenatide, which is marketed as Lixumia, combined in a single injection. So it comes as a single pen. So that's called as a combination injectable. So there is 2 different, so we have all used glargine. So what are the currently available combination injectable therapy that we have? One is iGlarLixi, for which I'm going to be showing you data for the next 10-15 minutes. And we also have iDeg-Lira, which is marketed as Zultofi, which is not marketed by Novo, but it's also available in some pockets for some limited usage in patients. So these are the 2 combination basal insulin that we commonly use associated with GLP-1 receptor agonist. So where can I use it? What are the approved indications? So as I told you, now this is available in India for the past few weeks for the management of patients with type 2 diabetes. Where do you use it? In patients obviously with type 2 diabetes, where you also need to address the weight. As I told you, majority of my patients who are on complex insulin regimens do complain about weight gain and of course the risk of hypo. So where I need to listen to the patient and address to them about the weight gain and the possible chance of hypoglycemia which can happen, it can be used as an adjunct in diet and exercise in patients who are also on OAD therapies, metformin with or without other OHAs, SGLT2, SUs. DPP4 has been studied, but once we start the molecule, we obviously would take the DPP4 off the prescription, or basal insulin or GLP-1 receptor agonist. So it can fit into your patient's prescription depending on how you would like to place this molecule. And as I told you, it would differ from one individual to the other individual. So why do we need this? I think we did have this slide in the morning when we talked about SEMA, right? So the combination of iGlarLixi targets 7 out of 8 pathophysiological abnormalities, right? So you are targeting the hepatic glucose production. It reduces the lipolysis and proteolysis and makes a better protein synthesis, increases glucose uptake in the muscle. So that's insulin for us. And we've been doing this for the past 100 years. And what does GLP-1 does? It works in glucose-dependent insulin release. Right now, all our guts would be with incretins and GLP post-lunch session, as I told you, right? When you have glucose, you will have the GLP that will be secreted. And that's why the risk of hypoglycemia is practically very low with these molecules, practically none, because the glucose acts as a switch to turn on and turn off the signal for secretion of GLP. And it reduces the glucagon release from the alpha cells, improves the satiety, and improves the reduces the gastric emptying. And this is something that we know from the time that we were using Byetta, where it was used for weight loss when it first got introduced 20 years before. And what are the complementary modes of action for basal insulin? And this is a very important slide. This will probably cover the next 9 minutes of my talk. So it's going to give you an effective HbA1c reduction. I'll show you data for that. More patients of yours is going to achieve glycemic targets with a single prick. As I told you in the previous slide, it's going to address multiple pathophysiological mechanisms. We know you're going to address the fasting component with basal insulin, and once you hit the fasting sugars, there will be subtle postprandial reduction as well. And now you add on a GLP-1 receptor in the same pen. Bingo, you also have a good postprandial blood glucose reduction as well. Weight benefits and neutrality, which is what we aim in patients who are on complex therapies for the management of diabetes, and practically low risks of hypoglycemia. We've seen that with basal experience with glargine, and now with GLP, we know glucose is the turn-on switch for this. There is very low risk of hypoglycemia, or no additional risk of hypoglycemia, and improved GI tolerability. I think this is a very important point. I want you to think about this point. I'll come at the end of my slide and tell you why there is an improved GI tolerability. I know when we talk about GLP, the first thing is, oh, nausea, vomiting, stomach upset. Of course, we need to talk to them about this side effect, educate your patients, but this is less when we use GLP as an independent molecule. I will show you the reason for that at the end of my presentation. So the global guidelines across different countries from ADA 24 to ACE and EASD acknowledge the use of combination injectable in patients who are not well controlled. You put them on basal insulin, then you need to intensify either with a prandial component. Here you can start them if there is a higher postprandial blood glucose at the beginning, put them on a combination of glargine with a GLP-1 receptor agonist, here lixisenatide. So what sort of evidence do we have? These are the available evidence. We will not be talking about all these studies in the interest of time today. So we have the Solimix trial, which I will show you the data on that, comparing the iGlarLixi with twice daily mixed insulin bias 30. And we will also talk about iGlarLixi in OAD uncontrolled patients. But apart from that, you also have Ramadan studies available, comparing it with basal bolus. There are systemic review and meta-analysis that are available comparing the IDEG-ASP and IDEG-LIRA. And there is a study which is expected to be published. There are 4 studies expected to be published in the current ADA with the CGM data, comparing head-on-head comparison with IDEG, as we need to wait for the data to see. But these are the currently available evidence that we have with iGlarLixi in the management of type 2 diabetes. So as I told you, we'll keep it simple for today. We'll talk about iGlarLixi with bias 30. Okay, mixed insulin with iGlarLixi. So this was a phase 3B randomized controlled trial. The study objective was multi-center open label trial in the phase 3B, comparing iGlarLixi once daily with bias 30, and these are the inclusion criteria. And India also contributed around 182 patients for this study. So this was an open label study. So what we found here is, this was a non-inferiority trial. So when we use a drug first in phase 3 trials, we first want to make sure it's working, right? So we know bias 30 works. We know how the HbA1c reduction. So first we need to compare it to see whether it's non-inferior to the study. So once the non-inferiority was met, then the superiority was checked with these studies. And that's what it shows here. It was non-inferior in HbA1c reduction with a statistical significance in superiority when you use iGlarLixi when compared to bias. And the important advantage of this is this. In terms of superiority, so here they didn't check for inferiority. They know this combination is going to be weight neutral, isn't it? Because you have GLP there. So GLP is supposed to help you with weight loss. So they wanted to see what happened to the weight loss, and there was no weight gain with the combination. It had a superiority in terms of weight neutrality and weight benefits when compared to bias 30. So those were the primary endpoints that were studied, and these were the other secondary endpoints that they looked into. What happened? How many of your patients got into HbA1c without weight gain? How many of my patients got into HbA1c without hypoglycemia? How many of my patients achieved an HbA1c of less than 7% when I use it for my patients with type 2 diabetes in comparison to BIASP 30. And again, total daily dose, there's no rocket science to it. Here we have GLP instead of a shorter acting insulin in the same pen, isn't it? So the total daily dose of insulin would be less here when compared to with the same glycemic efficacy, very slightly subtle superior glycemic efficacy with benefits in terms of weight and a practically very low risk of hypoglycemia. And that's how we actually start and use this molecule in our clinical practice. And as I told you, the incidence of hypoglycemia, for any hypoglycemia, ADL level 1, which was defined as less than 70, ADL level 2, which was defined as less than 54, both during the daytime and nocturnal hypoglycemia was less. Again, because we have a GLP-1, which is glucose-mediated insulin secretion, which is different from the BIASP 30, which we have the insulin combination there. So the advantage being here, weight neutrality, possible weight benefits, and a lower risk of hypoglycemia with the same or slightly superior HbA1c reduction with iGlarLixi. So to sum it up, it gives you a better glycemic control with weight benefits, lower risk of hypoglycemia, fewer daily injection, similar proportion of, I didn't show you the adverse effect, I'll show you at the end of the slide about the nausea part of it. It's efficacious, simpler, and well tolerated, alternate to premix BIASP if you have to start your patient. Somebody who has both fasting and postprandial hyperglycemia, and you have to start, this will be 1 shot a day when compared to 2 shots of BIASP 30. That's also an advantage. In terms of OAD, uncontrolled patients again, here, this was a study looking into patients who were on metformin, and they had 3 arms here. One was lixisenatide with metformin, iGlarLixi with metformin, iGlar, simple glargine, the insulin that we use. And these were the inclusion criteria that you see here. And if the sugars were uncontrolled, second agents, majority of them were sulfonylureas and glinides were added to the study. And what they saw here is superior HbA1c reduction. If you see here, the blue one here is the iGlarLixi that we are talking about, the Soliqua. The purple one is the glargine, and the orange one is the lixisenatide, the Lixumia. Obviously, when you have two combined injectables in the same pen, you are going to have a better HbA1c reduction, better fasting blood glucose reduction, and a postprandial blood glucose reduction. All I would like to focus on the dark blue bar on the bar chart, and the 7-point SMBG again. A lot of times when we talk about lixisenatide, we talk about whether it's a 24-hour duration. We need the CGM data to see that, which will be available by the end of this year. But the SMBG showed if you see from baseline, which is the top graph, to the bottom graph, which is week 30, you see an improvement. The dark blue lines are the one at the bottom is the iGlarLixi, where you see a reduction not just in the fasting blood glucose level, but also the postprandial blood glucose reduction, which is what is required for your patients to get a target HbA1c without the side effects. And here again, I'm going to sum it up. So I think this is, I only have 2 minutes, and I think this is the most important part of the slide. I just missed one slide in the interest of the time. So what about the pen, dose, titration, and use in special population? I think as a clinician, that's what we need, right? Of course, we need to know the studies. So this is how it's available. In US, there are 2 pens available. Let's not complicate it. In India, we have only 1 pen. So it's 1040 pen. In US, there are 2 different concentrations pen that are available, which has been used by my colleagues. But here, it's 1040 pen. This is the units. So if I start somebody on 10 units of glargine, you're only starting them with 5 microgram of lixisenatide. That's why the nausea is very less. See, normally when I use Lixumia, I would start them on 10 microgram and then go up to 20 microgram, right? But here, I'm not going to start with 10. Probably if the patient is already on glargine, I'll put them on the full dose, right? Otherwise, it's the dose titration. By the time you step up the dose with slower fasting blood glucose reduction, by the time the patient comes to 20 units of glargine is when you have the 10 units of 10 micrograms of lixisenatide. That's why the GI side effect is less in the combination pen when compared to any specific other GLP-1 receptor agonist. But nevertheless, nausea, vomiting, all those things have to be discussed with the patient. But it's lower in the studies I only have 3 patients right now. I can't tell you my experience, but maybe perhaps next year, the same time, we'll have more patients here to share our experience with nausea. And this is the concentration of this. None of us are going to remember this. You can take a photo of this and keep it, and every time I use it, I still refer to it because I don't remember it by heart. But as I told you, 10 units will give you 5 micrograms of lixisenatide, and that's practically why the nausea is less. And I'll take 1 minute more, sir. So if somebody is insulin naive, you start with 10 units with 5 microgram. If they're already on glargine more than 20 units, you can start them with 20 units, which will give you 10 micrograms of lixisenatide. So as a pen that I showed you. And this is how you titrate. You titrate pretty much like the way you titrate your fasting blood glucose with glargine. Ask your patient to do a self-monitoring blood glucose data, and you titrate it. If you have a CGM, of course, you can also look into the postprandial blood glucose and see how you can modify the diet, etc. But this, of course, you can have your own algorithm to titrate your fasting blood glucose and how do you want to step up the dose of glargine, which will also give you a step up in the lixisenatide dose. This is my last slide. With this, I'm done. In terms of special population, we have data, specific study, which we didn't talk about today, in elderly patients more than 65 showing it's safe. In renal impairment patient, it can be used with mild to moderate renal impairment. We do not have studies in severe renal impairment. So right now, the current label update is only this. And hepatic impairment, it can be used in patients with hepatic impairment. Again, in patients with liver and renal, always have to be mindful of the GI tolerance and GI acceptability with these molecules. It's currently not approved in pregnancy, right? So this is the special population indication with iGlarLixi, which is called Soliqua. And so it's 1 injection once a day. It has to be given 1 hour prior to the meal. 1 hour prior to the meal is how we were giving lixisenatide, and that's how we are supposed to give. While we know basal can be taken anytime, right? So 1 hour before meal is how we give. So to sum it up, it's a synergistic once daily combination injectable of basal insulin glargine U100 with the prandial GLP-1 receptor. That's where it differs from the bias, the basal bolus therapy, and all the other regimens, the co-formulations. This provides effective fasting and postprandial blood glucose reduction. We talked specifically about 2 studies. We'll probably have a dedicated meeting for this where we can also address the Ramadan studies in special population, elderly population, showing that it's efficacious, simpler, well-tolerated, provides better glycemic control with weight benefits and less hypoglycemia, and that is exactly what we need in our patients with type 2 diabetes, with 1 single prick a day, 1 hour before the meal. With this, I finish, and I thank the organizers for giving me this opportunity. Thank you.